Welcome to today's edition of Pathcast. Today is March 19, 2024. It's a Tuesday. I'm Rifat Mannan in California. Today, we are very delighted to have Dr. Alessandra Smith, who is a consultant in the Department of Pathology at Mayo Clinic, Arizona, and she is a very renowned pathologist with special expertise in head and neck pathology. And she had presented before on our platform, and today she is back, and we are happy to have her back with us. And today she is going to talk about challenges that we face in our day-to-day practice of head and neck pathology during frozen section or intraoperative consultation. And I hope everybody will benefit from this talk. And thank you so much, Dr. Smith, for joining us today. And over to you now. Thank you.
Good morning, everyone. Well, thank you so much for inviting me to be here again to give you another talk. It's my pleasure to share, some of my cases with you. And this morning, we'll be talking about some frequent challenges in intraoperative consultation of the head and neck. So my goal with this talk is to make you comfortable in some difficult situations, and I divided the talk in a total of couple different areas. And I just want to, give you some advice when the situation comes, which way you should jump, right? Like if I can point you towards the right direction, I'm hoping, that that's going to be very helpful to you in a very stressful situation. So we will start with the evaluation of margins or the diagnosis during head and neck frozen sections. And we are faced with two challenges, the diagnosis of invasive carcinoma and the evaluation of dysplasia. So what are the problems with evaluation of invasive carcinoma at margins in a head and neck frozen section case? So if you give a false positive diagnosis, the patient will undergo an unnecessary resection. And if you give a false negative, that means if you miss, the cancer at the margin, the problems are that a re-resection may not be possible because the patient may have already been undergoing reconstruction. And also that patient, he will require radiation that otherwise would not have been needed. So, and the side effects of radiation, they are not minor. Patients can have jaw osteonecrosis in about one fifth of the cases, and also they may end up with a non-functional larynx. So that's really horrible. You should be aware of that. So what is the definition of a negative margin? Well, in the oral cavity, a closed margin is a margin that if the cancer is within less than 0.5 cm from the margin, and that will incur in an increased risk of recurrence. An optimal margin would be more than 1 cm. Now, in the larynx, a free margin can still be considered within 0.5 cm. That might be sufficient in the larynx. Now, if the margin is closed, the surgeon might choose to chase it if the patient has already failed radiation therapy, and that is good to know. So you may want to provide the distance from the margin from your closest margin, and then the surgeon will decide if he wants to chase it or not. So now we'll jump right into some real-life frozen section cases. Starting with this is larynx biopsy. You can take a look and think about what would you say about this case. So when you look close, you see that those nested areas that may make you think could be cancer, they are actually vessels. So the vessels can look really plump on frozen section and may mimic carcinoma, but you look close, you can see the red blood cells inside, the vessels, and then it becomes easy to say, oh, that's just, granulation tissue, like reactive changes in this background. Now, different case. So this is a perimolar lesion, and the clinical history was of metal allergy, and there were several biopsies prior that they all had been called negative or carcinoma. So you see there are multiple fragments, and when you look close, you see this proliferation of well-differentiated squamous epithelium is very well differentiated, but there is some degree of cytologic atypia, right? And when you look even closer, you see maybe there is paradoxal maturation and there is premature keratinization. It's very bright pink, look to the epithelium, and some more atypia. And some of the nests have very abnormal architectures, like a medusa head, but still, it looks extremely well differentiated. Now you go back and you realize the architecture is way too complex. This is too much. So this is like not reactive. So this is the H&E. This is well differentiated squamous carcinoma, and you can see that there were even like neutrophils that could make you confused and think, oh, maybe there was just some sort of like reaction to inflammation or something. But no, this case was actually a very well differentiated squamous cell carcinoma. Now, it's very important to know that for you to diagnose well-differentiated squamous cell carcinoma on frozen section, you should be very sure, because there are entities like granular cell tumor that can mimic invasive squamous cell carcinoma. Like, this remarkable pseudoepitheliomatous hyperplasia that can happen, that can be a real challenge. This is an H&E. I did not have one case of this on frozen section, but I thought it was good to like highlight that you should always make sure, look at the stroma to make sure you don't overcall, this tumor as invasive squamous cell carcinoma. Other clues is that look for desmoplasia, look for atypia, and be very careful diagnosing squamous cell carcinoma if you don't have desmoplasia or if you don't have atypia. And always make sure to look at the stroma. This is still the granular cell tumor case. So another pitfall you can have is tangential sectioning that can mimic invasive squamous cell carcinoma. But make sure to look at the low power and compare the area you're worried about with the adjacent. And also if you want to get some deeper levels to make sure, to see if everything is going to connect or not. So again, your clues that this is not invasive squamous cell carcinoma is that you don't have desmoplasia. And when you can see the fibrovascular cores in the area you're worried about, that's also reassuring, okay, that could be just tangential sectioning. Now, this is not normal mucosa, this is dysplastic, but we'll talk about it later in the talk. Now, take a look at these two pictures. Which one do you think is cancer post-radiation and which one you think is benign? I'll give you just a couple seconds. You kind of decide which one is which. So this is carcinoma and this is benign. So you can see in benign with radiation changes in fibroblasts, you just have isolated cells here and there, with abnormalities. Whereas in carcinoma, you have significant cytologic atypia. You may see mitosis, dyskeratotic cells with this bright pink cytoplasm, and these changes will really favor, that's carcinoma. That's not reactive. Also, skeletal muscle can have, reactive changes that may make you worried, like you see this multinucleation. Okay, but a clue that you're dealing with skeletal muscle is that you kind of have a transition from the most abnormal areas towards normal areas, okay? And skeletal muscle can also have pigment, like look here and there, you can see pigment. And in favor of squamous cancer would be, again, the keratotic cells and a lot more pleomorphism. A different case now. This is a patient that had already had lateral tongue resection for squamous cancer, and now he had a suspected recurrence in the posterior tongue, and this frozen section was made for diagnosis. So the surgeon said, I'm really sure this patient has recurrence, but I will keep sending you tissue until you tell me that you have cancer. So I already had like numerous slides, numerous fragments, and I was looking at this and I was like sweating and anxious, and I couldn't find the tumor. And I look here, look there, I see, all these post-surgical changes, and maybe like it's very confusing because you think like, is this desmoplasia? Is this just reactive? I don't know what's going on, and this is just so hard. And you look, you see ducts. The ducts can have some atypia, post surgical, and all this like inflammatory process that goes along with post-surgical. And okay, now where is the cancer? And more fragments come my way, and then I look around and I still not sure I see cancer. And then I found this one little fragment that I have magnified here to like 10 times bigger. But you see how this fragment, you see this marked pleomorphism, a couple mitotic figures, but you also see how irregular it is, and it's like invading muscle in a very regular fashion, very regular borders. So finally, I got to the diagnosis of invasive squamous cell carcinoma, but after looking at multiple fragments and looking at high power and checking out the architecture of this abnormal fragment. So this is not, and now like you look at this high magnification, this is not a difficult diagnosis, but in the context of frozen section that you're looking for it, it's extremely stressful, and it's really challenging. So check out this oral cavity biopsy. This is a biopsy. This is H&E. Again, I don't have a frozen section, but it's very important for you to like look at this and be aware of this entity. You see like this epithelial nest, they're way down into the stroma. And if you get this in a frozen section, you might be very worried that you might be dealing with squamous cell carcinoma. So these are actually entities you just have to be aware, okay? And the clue is that they are bland. So all these developmental rests, okay, they can look very bland, but they can mimic squamous cell carcinoma in a frozen section. And the justaoral organ of Chevitz, okay, it's just a normal structure. Nobody knows why it's there, but you have to be aware. It happens in the deep soft tissues of the angle of the mandible or retromolar trigon, okay, and that's why in a resection for a invasive squamous cell carcinoma you might come across this entity, and it can be associated with nerves. So it may be mistaken even for perineural invasion. But if you compare this with the tumor, you see this is extremely bland and your tumor is going to be extremely pleomorphic. So if you're not sure, you can always go and take a section of the tumor to look and compare, okay? And this benign thing is always going to look very bland. Now, different case. So this is oropharynx. This patient is undergoing a re-excision because he had a previous HPV-associated squamous cell carcinoma that had been incompletely excised with positive margins. So you get an epithelium that looks like this in a margin. It's very basaloid looking. The cells have higher C ratio. And you might start feeling a little, anxious. You might be dealing with positive, again, margin. And then you look at this, you might think, oh, those non-keratinizing is this infiltration or what's going on, So now you kind of have to make the call the surgeon. Are you going to tell this is positive margin? Should he take more tissue or no? So this is the permanent section now. This is the P16 dead negative. So that is not the prior tumor. What is this? This is necrotizing sialometaplasia. And how do you figure that out? So when you see, that the nests are, they're deep, but they're somewhat well circumscribed, and you compare this with like benign minor salivary glands, they have about the same, shapes, and no, there's no mitosis, no apoptosis. So, but they can be a little atypical, and you can have like rare mitotic figures, but if you don't have any mitosis, any apoptosis, you have to be aware that this might be something benign, okay? And again, what is extremely helpful is that you go back to low power and compare with the adjacent minor salivary gland tissue. So this is extremely important to be aware, especially like post-surgical, because damage to the mucosa can induce the necrotizing sialometaplasia. So now this is a tonsillectomy, again, a frozen section for HPV-associated squamous cancer. And you can see how hard it can be to spot the tumor, right? Because the tumor is like so blue and admixed with the blue background, it might just be extremely hard in the frozen section setting. And you can compare here with the P16 highlighting the tumor. And that's going to be a challenge. Now, my clue for you is that if you can, just freeze the entire tumor with the adjacent margin, because then you can get the architecture and you can see how far the tumor is going from the margin and how is it behaving according to the, adjacent tissue. And in this section here, it became more clear to see, how this architecture is extremely abnormal. And so you see the margin is still negative, but it's very close. So another clue for you to figure out if it's cancer or reactive, you're going to look at the cytology, right? So let's compare here. This is a benign crypt compared to HPV-associated squamous cancer. So you can see the pleomorphism, the higher NC ratio, multinucleation, right? That goes with cancer, and also a ton of like mitotic figures and apoptosis, right? So those are very helpful clues for you to differentiate the carcinoma from benign crypts. Now, this is just a tonsil biopsy sent for frozen. What is your diagnosis? So it's polypoid, right? And you might not be sure, is it invasive? It's not invasive. But in this context of oropharyngeal carcinomas, okay, you already know that if they can be HPV related, you don't say in situ, just say carcinoma, okay? Once you're in this location, the morphology of this location is different, like the vascularity and the basement membrane, they're different. So even something that looks in situ in this spot might already be invasive. So that's why you don't say in situ, just say squamous cell carcinoma, okay? Now, moving on to the evaluation of squamous dysplasia at margin on frozen. Now, a couple years ago, a friend of mine asked me, Alessandra, could you please, make a lecture explaining, how can you tell if it's, the margins are dysplastic or not, and how do you do that on frozen? And I told my friend, just forget, that's impossible. I'm not going to be able to do that. It's too hard. Dysplasia is too hard. The margin is hard, and frozen section is super hard. So I can't do it. And it just took me a really long time to process all the information and gather the cases to kind of make some sort of plan to be able to explain to people, how do you do this? So how do you do this? Well, first, you need to understand what are the goals with the evaluation of dysplasia at frozen section. Okay, that's first step. And what are the goals? Well, it's going to depend on the case, but the general rule is, if you see something that looks like low-grade dysplasia, that means that patient does not need any further resection. And if you miss it, it's no problem at all, because the surgeon will not try to excise more if you say low-grade dysplasia, okay? Now, high-grade dysplasia, in the other hand, the surgeon will try to resect more tissue if he can, okay? But it becomes a problem mostly like in small resections, okay? And if the resection was done for high-grade dysplasia or for a very small carcinoma and you miss it, then it's bad. Then the surgeon will be really upset, and that's not a good outcome. But let's say the surgeon is going for a very large tumor that already has metastasis, right? Then if you miss high-grade dysplasia in that setting, then it's not that much of a big deal. Or even if you don't miss, you call, there is high-grade dysplasia at the margin. But if the surgeon thinks it's going to be too morbid to try to chase it, he might just leave it alone. Okay, so this is really important for you to understand. Now, this is a resection for a minimally invasive oral squamous cell carcinoma, and this is a frozen section margin, a perpendicular section. You see the ink where the true margin is. And I'd like you to take a look and kind of decide, do you think this is normal, dysplastic, low grade, high grade? Just kind of look at it, make up your mind, think about what would you say to the surgeon, okay? So main thing is that, do you think this is high grade? Because if you think it's low grade is not a big deal. The main thing is, do you think this there is high grade here? And how do you figure that out? Very helpful clue. You look at the center of the lesion. You take a section of this. Ideally, if the specimen is small, try to freeze the entire specimen, including the lesion, because then you can compare the center where the lesion is with your margin. And that's extremely helpful, okay? So now let's compare. So this is the center of the specimen compared with your margin, and you can see that in the center there is way more pleomorphism. There's the nuclear bigger, more hyperchromatic, and like totally, worse, way worse than what you see at the margin, okay? And also the architecture. Look at the architecture, how abnormal it is in the center. You have like broad, reedy, and you have tiny ones, and you have budding, and this is like extremely abnormal compared to your margin that looks like it's maturing just fine. Okay, so your margin was not high-grade dysplasia, it was just low-grade, and this is some frozen section artifact, so no big deal, no problem. So how do you define low-grade? Well, it's not super simple, but basically, if you see that the nuclei kind of floating, starting to fly away from the basement membrane, and the basal layer starts to become expanded by these basaloid-looking cells, and this nuclei look very jumbled and disorganized, that's when you start to think, okay, this might be low-grade dysplasia, okay? Now, what are the challenges with low-grade dysplasia? The challenges is that the immunostains, they are usually not very helpful, okay? And general rule is that you should only use P16 immunostain in the oropharynx. And people get very confused. They use P16 other sites where they should not. And oropharynx sites are these, okay? So remember that, be very careful, select the P16 only in these sites. Another challenge is that, of course, grading extremely subjective, and the way we grade is a combination of architecture and cytology, but that's kind of like an art. And there is another challenge is, what do you say? You say high grade, low grade, moderate, mild, moderate, severe. Like what do you do? Well, the WHO recommends that for both oral cavity and larynx that you keep it as low grade, high grade, and CIS, carcinoma in situ, okay? But many experts in the oral cavity, they still mild, moderate, severe, and severe equals to carcinoma in situ. Okay, now how is this gonna work? Well, so let me explain a little bit more about dysplasia. So dysplasia, broadly speaking, you have non-keratinizing and you have keratinizing. But, in the head and neck, keratinizing is way more common than non-keratinizing. And the way we are taught, we think of like, low grade or mild, the dysplasia is only like in lower third, like in the cervix, moderate, middle third, and severe full thickness. But those rules, they only apply for non-keratinizing. Keratinizing does not follow these rules, okay, as in the cervix, uterine cervix. And the reason is that you can have invasive squamous cell carcinoma arising from high-grade dysplasia that does not look like full thickness. So that's the reason why keratinizing dysplasia it just doesn't follow the rules, okay? So you don't need full thickness atypia to call something high grade, but instead you should focus on the severity of the features. You should focus more on the severity than on the level that you see the features. And this slide just shows a summary, okay, of all the architectural features, abnormal architectural features and cytologic features that you can have. And you can, do your best to try to memorize all this. And when I was reviewing this topic to prepare this lecture, I came across this paper that the WHO has proposed, how many criteria you need to call something high grade. So this paper summarized that for high grade, you need at least 4 architectural features and at least 5 cytological features to call high grade. And if you have less than that, then you call low grade, okay? And they also added a few new additional criteria that also indicate the presence of dysplasia, like apoptosis, right? Single cell keratinization. And you can, read this paper and you get like better picture of this, okay? Now, just trying to memorize all these things, I kind of like to compare with, kind of try to learn how you learn to dance ballroom. You can try to read books. That's going to be very confusing. It's not going to work. You can try to take lessons, do your best. And even like this is myself, trying to learn, a couple steps in Viennese waltz, but it just doesn't work if you just do a little bit here and there, because in the frozen section setting, it's kind of like you're in a ball, right? And trying to dance the Viennese waltz, it's like lots of moving parts, and you really have to practice a lot to get to the level that everything works beautiful, right? So I will keep trying to help you out. This is another table, with a couple more summarized features. And what I want to show you with this table is that you really have to put an emphasis of the degree of the abnormalities, okay? The more the more significant the cytologic atypia, the more you have nuclear irregularity, pleomorphism, and hyperchromasia. Those are the things that you push you towards high grade, okay? So here you go. Now, another thing you should know, if you have atypical mitosis and profound nuclear pleomorphism on its own, that is already sufficient to call something high grade. You don't need anything else if you have these two, okay? Now, this is an easy case, severe dysplasia. You have severe architectural and cytologic atypia. Okay, fine. That's easy. Like you see marked pleomorphism. These cells have this appearance like they're kind of they look like edematous. Like you see the bridges are very prominent. That's some sort of discohesion going on inside the nest, this hypereosinophilic look, and this kind of budding nests, and very marked degree of cytologic atypia. And so when do you say moderate? Okay, so you have to know that moderate, if you say moderate, it belongs with high grade, okay? So moderate dysplasia is when you see alterations that go from the basal layer until the mid portion of the spinous layer, okay? So that means the epithelium is still maturing and all that. But in real life, what I see is that moderate dysplasia gets diagnosed when there is a real challenge separating low grade from high grade. Okay, that's real life. Now, if you're thinking about diagnosing low grade, but you see budding, the minute you see budding, you upgrade from mild to moderate. You see, this is not mild anymore, this is moderate. Okay, now the minute you start to see marked cytologic atypia, then that's not moderate anymore. Then it becomes severe, okay, or high grade, or moderate is high grade. But if you see marked cytologic atypia, you go to severe, okay, if you're using the 3-tier system. And when do you say carcinoma in situ? So this is another area for a lot of confusion, but the definition is that you should see full thickness dysplasia. But what most experts do is that they only say carcinoma in situ when these changes are extreme, or if the patient is already known to have squamous cancer. But technically, it is the same as you call high-grade dysplasia. Okay, they are synonym. Now, how do you distinguish from reactive? And I'm just going to go very fast, very briefly, very quick overview. How do you do this? So this is not always possible, and especially, of course, in the frozen section setting. Now, just look at these two pictures. Which one would you say is reactive? Which one would you say is dysplastic? You just take a look, make your best judgment. So what are things that could help you? You have to check the clinical history, okay? What's going on with the patient? Is the patient smoker? Is that, what's the clinical impression? Is lichen planus? Do you see candida? Was there previous radiation? So those are all things you should be aware of, okay? Now I'm gonna give you some clues. If you see a ton of chronic inflammation, okay, especially if it's under the surface in the submucosa, and the mucosa is not inflamed, but under the mucosa there is a ton of chronic inflammation, that is not a reason to step back from dysplasia. Quite the opposite, because dysplasia, you can have a ton of chronic inflammation associated with dysplasia. But if you see acute inflammation, then you back off, okay, and reconsider. So here you see all these neutrophils. So this is reactive and this is dysplastic. But of course, there is more to it, okay? And I'll show you a couple more clues. So in reactive changes, the nuclear, they are kind of uniformly atypical. They're all round, right? Mostly round. And the basal layer is somewhat intact, and the more atypical cells are kind of above the basal layer. Whereas in real dysplasia, the nucleus there is more hyperchromatic, and there's more heterogeneity, right, in the look, more coarseness of the chromatin. And also, if you see atypical mitosis, then you should go towards a dysplastic process. Other clues, and you can check out the architecture. If it's very symmetric, you have to think reactive before dysplastic. So if you see a gradual transition between the abnormal area and the adjacent areas, that also goes with, reactive. Now, abrupt transition, disorder maturation, that would go with dysplasia. different case, frozen section, nasopharyngeal mucosa. Do you think this is dysplastic? So you see all these basaloid looking cells, kind of high NC ratio, in a very thin epithelium. So this is immature squamous metaplasia, okay? So this can mimic dysplasia because these epitheliums look so kind of basaloid and high NC ratio. You might think you have dysplasia, and the cells, they might have a little atypia. They, nucleus might be a little enlarged, okay? But your clues is that in a thin, non-keratinizing epithelium, if you don't see atypia, what is the atypia? I'm sorry, if you don't see mitosis, and if you don't see apoptosis, and there is no, hyperkeratosis, that those are clues you might just be dealing with, squamous metaplasia, immature squamous metaplasia. And you look at those cells, they have very round contours, kind of nucleus is kind of tapering off, and kind of teardrop shapes. That's not dysplasia. So we are moving on towards our second topic in the challenges in head and neck frozen sections. We are going to discuss a few polypoid lesions in the sinonasal tract and the nasopharynx. So you get this biopsy for frozen section. This is a 65-year-old man with basal skull mass, and he had chronic sinusitis. And the surgeon wants the diagnosis. So you look at this, what would you think? Just start thinking about it. So these are your possibilities, okay? In this spot, these are all things that could happen. You can have inverted papilloma, inflammatory polyp, cancer, all kinds of like other lesions. So usually the main question is this an inverted papilloma? Okay, you need to figure this one out. You see there is some invagination, there's a lot of inflammation. Do you think this could be inverted papilloma? So if you're not sure, you look at this, I don't see it, I'm not sure. Just if you don't have the diagnosis of inverted papilloma, you go ahead and you freeze all the tissue that was submitted to you for frozen section to make sure you rule out inverted papilloma in the tissue that was sent to you. Okay, and why is that? Because if you call the specimen positive for inverted papilloma, the surgeon will attempt a complete excision, okay, and that might be very significant, and he will try to get free margins. So he might send you separate margins. And if you say, this is just inflammatory polyp, he will stop. Conservative excision, end of story, okay? Now, how does inverted sinonasal papilloma look like? So you have this invagination of like very hyperplastic looking epithelium into the stroma. This epithelium can be squamous, respiratory, or transitional, and many times you have associated neutrophilic infiltrate. Other types of papillomas you can have oncocytic, you can have exophytic papillomas, and that's all things you should be aware. Now, what are the challenges? So sinonasal inverted papilloma can look like an inflammatory polyp. It can look very edematous, kind of areas adjacent to it can look edematous, and the inverted features might be very focal, okay? And you might not have all that much inverted growth pattern. So that's why you should submit your entire sample, make sure you don't miss it. And also, especially on permanents, the entire tissue should submit it for evaluation because you have the risk of malignant transformation. Okay, so you have to make sure there is no cancer arising in this specimen. So going back to our unknown, I show it to you in the beginning of this session. You see, again, there is invagination of some of the surface, but would you call this inverted papilloma or maybe not? What would you think? So let's compare. Okay, this is our case compared to a sinonasal inverted papilloma. You see that there is a difference here. Basically, this epithelium is not thick. It is kind of pseudostratified and really not that thick compared to papilloma that you see really, really thick epithelium. So this was just an inflammatory polyp, and it's like the easiest diagnosis to make on a regular H&E, but on frozen section, you might be, stressed out, and you might have trouble making the correct diagnosis if you don't know the specific criteria. So another entity you may come across in this differential diagnosis is respiratory epithelial adenomatoid hamartoma, or RIA. Okay, this is just a benign overgrowth of indigenous glands that they arise, sometimes in continuity from the surface. And because they're so invaginated, you might worry, it might be inverted papilloma, but they're somewhat like widely spaced, lined by ciliated respiratory epithelium, surrounded by a thick basement membrane. So when we compare, you see that both RHEA and Sinonasal inverted papilloma, they have this inverted growth pattern. But what would favor RHEA is that epithelium is not really thick, okay? It is just pseudo-stratified and not truly stratified like inverted papilloma is, okay? And also, if you happen to see this periglandular hyalinization, that might also be helpful. So in summary, sinonasal inverted papilloma, you have this really, thick epithelium with lots of intraepithelial neutrophils. That might be a helpful feature sometimes, and especially if it's only in the epithelium, not in the stroma. But this case, it's in both, okay? Just be aware of that. Another frozen section, okay, this patient had a history of inverted papilloma, and you have just a couple, fragments of papillary mucosa, and you look at high power, you see there is a little bit more hyperchromasia and cytologic atypia, maybe apoptosis over here, and then you start to feel little nervous. You look at another section, and there's even more cytologic atypia, and like, what would you think about this? Well, what would favor squamous cell carcinoma over sinonasal inverted papilloma is the prominent cytologic atypia, and this is the H&E, okay, and high mitotic activity. So this case is squamous carcinoma arising in the setting of patient with this history, okay, of sinonasal inverted papilloma. Which additional features would make you worried that the carcinoma is arising from sinonasal papilloma? So you look at this low power frozen section, you see this kind of broadness, like much broader than you normally would see, kind of irregular, with irregular shapes at the base, and they might be fusing. Those are features that should make you very nervous you have cancer. And then when you start to see very high mitotic count, atypical mitosis, pleomorphism, necrosis, communal necrosis, those are features of squamous cell carcinoma. And this is just a table for you to compare, and you can read when you have more time, what are all the features. But basically the stains, they're not going to be so helpful, and it's basically morphology, okay? So moving on to our third topic of problematic head and neck frozen sections. So we have neck masses. So in the neck is like the Wild West, right? Like you don't know what's in there. There could be so many things in the neck, and most times the clinician or the surgeon, they don't tell you what is it. They just say, neck mass, right? And you go figure it out. But there are so many different landmarks. There are lymph nodes and salivary gland and vessels and soft tissue, and there's a whole, huge mix in there. Now, it's very important that you keep in mind when you have frozen section for neck masses, okay, you have to make sure that whatever you're going to diagnose, that you don't get confused with a metastasis to a lymph node. That's the biggest risk, because the minute you say metastasis or positive for metastatic carcinoma, the patient will get neck dissection, okay? And if that's not the case, then you're in trouble. That will lead to unnecessary neck dissection, okay? So this is a real case, 43-year-old man, 3 cm large cystic mass in the neck. And you see, it looks like it's inside a lymph node, and this cystic mass is in level 2-3, and that spot is like a hot spot for metastatic HPV-associated squamous cancer. So you should be very worried that might be the case. Okay, but you look around and then look at high power, and you see the squamous lining that does not look super atypical, and adjacent lymphoid tissue. And if you're not sure it's squamous cancer, then you don't call it. You might word it like, there is an atypical squamous lesion or well-differentiated squamous lesion with cystic change, cannot exclude squamous cancer. You should be very worried that it could be squamous cancer, but if you're not 100% sure on frozen, then you don't call it, okay? Now, this is the permanent slide. So the pathologist went ahead and he did a P16, because we know, HPV-associated tumors are strong, block diffuse, P16 positive, and this case was positive. So does this mean, is this metastatic HPV-associated squamous cancer? Well, this was not. This is branchial cleft cyst. So how do you figure that out? So branchial cleft cyst, you see this lining is extremely bland. there is no invasion of the underlying lymph node stroma. What you see is you can have invagination, but no true invasion. And if you're still not sure, you can do HPV in situ hybridization for high-risk HPV, and negative, that is further reassuring that this is just branchial cleft cyst, okay? Now, different frozen section. So this is a parotid mass, okay? So you see here benign parotid gland tissue, and on the frozen section, you see this infiltrative lesion that it looks like it's going to the margin, and it looks like it's invading, and it looks like a carcinoma, and you're very worried about it, and you go check out the history, and yeah, this is the previous fine needle aspiration. This was the cell block. There was very paucicellular, but this one cluster in the cell block, you see these dark blue cells with some mitotic figures. So this was called basaloid salivary gland neoplasm, but the presence of these mitotic figures, that's a red flag, right? Maybe something not low grade. I don't know, what could this be, right? So then you look again at your frozen section and you try to see, what does this look like? A salivary gland tumor? What does it look like? It's very basaloid and infiltrative, and there is necrosis, and it looks like there is high grade cytologic atypia. So just looking at these cytologic features, I would say, so it's a high-grade tumor. And if it's a high-grade salivary gland tumor, then the patient gets neck dissection and complete, salivary gland resection and neck dissection. So now be very careful before you say something like that, and without knowing the entire history. I was lucky enough, my surgeon came into the room and he started talking about this case, like, yeah, this patient had the basal cell squamous carcinoma sitting on this spot 6 years ago that has been excised previously, and now he had this mass growing in the parotid in the exact same spot. It's like, okay, so here we go. So this is recurrent basal cell carcinoma invading into the parotid. So this is a lesson that you have to be very, very careful before you diagnose a high-grade lesion arising from the parotid as a primary. Make sure you exclude metastasis or secondary involvement, because when you're dealing with like high-grade lesions in the parotid, is a lot more likely to be metastasis or secondary involvement than a primary. So you always check the clinical history, okay? Different case, intraparotid lymph node. Just so be aware that intraparotid lymph nodes, they can have benign inclusions. Make sure you don't overcall this as some sort of weird metastasis. Thymic tissue very often mimics lymph node, okay, but there is no true capsule, and you see the Hassel corpuscles here and there. So very, very important to be aware of this, because you might get confused and you might think this is metastatic squamous cell carcinoma to lymph node, okay? Another tumor you should be aware, mucoepidermoid carcinoma or many salivary gland tumors, they can have a cuff of associated lymphoid tissue. So it's very important that you don't call it metastasis unless you're absolutely sure. And how can you be sure? You look close at the interface, and there is no real lymph node architecture. There is no lymph node capsule. What you see here is the mucoepidermoid carcinoma invading the adjacent tissues, and even like perineural invasion. And the minute you see perineural invasion, it is carcinoma, okay, and you're done. But this is not metastasis, no true lymph node architecture. Another significant pitfall when you have parasitic thyroid nodules, and this is very common in the setting of nodular lymphocytic thyroiditis. And this can be a real pitfall because you think you might be dealing with a lymph node, but again, you don't have a true capsule. What you have here is, is just this kind of fibrotic tissue, and the lymphoid tissue and the thyroid follicles, they're kind of admixed. And it's very tricky because when you have lymphocytic thyroiditis, you can have reactive changes, and that can mimic, PTC. So be very aware and try to find out about the clinical history. Make sure you don't overcall PTC in this setting. Now, different case, you receive this sample and the surgeon tells you, oh, these are lymph nodes. What's your diagnosis, Dr. Schmidt? So you look at it, okay, so if you're telling me these are lymph nodes and I see round nodules of thyroid, so could this be metastatic thyroid carcinoma to lymph nodes? Well, make sure, look at it carefully, because you can have around the thyroid gland parasitic nodules, and those can mimic metastasis, okay? So this is not metastatic thyroid carcinoma to lymph nodes. These are just parasitic nodules. And you look close, this even had like some sort of fibrous tissue around that were kind of mimicking a capsule, but that's not metastatic thyroid carcinoma. So now we got into another tricky topic, that is the thyroid on frozen sections. And I wish we never had to do these frozen sections, but sometimes we still get them here and there, not so common anymore, but a few of you might still be dealing with this problem like all the time. So I thought better just to talk about it. So why is it so hard? Because even benign thyroid on frozen, you might think it's atypical because there is some frozen section artifact and cells look weird. It doesn't look quite like the H&E. But if you're familiar with cytology, if you want to make some smears and stain, that might help you, right? Or another tricky case here, that this biopsy was sent as perithyroid tissue, and it's somewhat like there's thyroid tissue kind of trapped in this fibrous tissue, somewhat like make you think, could this be perineural invasion? What's going on, right? So be very aware that, because you can have thyroid tissue, the thyroid doesn't have a true capsule, and the thyroid tissue can be a little admixed with the adjacent fibrous tissue or skeletal muscle. So don't overcall that as invasion. And all this was just benign thyroid tissue kind of mixed with adjacent fibrous tissue. There was a previous FNA. Sometimes you can have displaced thyroid follicles. So just be aware of that. So when you have benign thyroid nodule, or when you have a thyroid nodule in the setting of lymphocytic thyroiditis, like I was telling you, all the changes you can have in the follicles might mimic PTC. But the clue is that those follicles, they're going to be very admixed with the lymphoid tissue. And when you have PTC, the PTC will be kind of expansile and will push the lymphocytic infiltrate kind of like away, right? And if you're not sure what you do, you compare the nodule that you're evaluating with the adjacent tissue. And it really has to be, the cytologic TP has to be a lot more in the nodule than in the adjacent tissue for you to call PTC in the setting of lymphocytic thyroiditis. So if there are so many problems, why would you even do frozen sections on thyroid? So these are a couple reasons. Some textbooks and what some surgeons told me, I want to confirm the tumor size. That's why I want this frozen. Or I want to rule out anaplastic thyroid cancer. I want to rule out medullary because they have different treatments. I'm going to have to do a total thyroidectomy if you tell me, Dr. Schmidt, that this is medullary thyroid cancer. And if their lymph nodes are enlarged and you say medullary thyroid cancer, I'm going to do no dissection, right? So be very aware of that before you diagnose medullary thyroid cancer, that there's going to be like a lot more radical, surgical approach. Now, the challenge is because medullary thyroid cancer can have so many different patterns that I kind of call it the melanoma of the thyroid, because it can mimic other entities in the thyroid. And this is actually medullary thyroid cancer. You see, it's kind of solid and some follicles. And again, a couple more high power views of that tumor. You see how it's making follicles. So it can mimic like a follicular lesion or a hyperplastic lesion. It can even have pigment. So you could mimic, let's say, a metastatic melanoma to the thyroid. And the nuclear features, unfortunately, the salt and pepper features, these are H&Es here on the right side. They're not very obvious on frozen. But again, if you want to try to do a smear, and if you're in an institution, they are very good about making FNAs, before the frozen. That would have been lifesaver, or measure calcitonin levels. Those would have been very helpful for you. Other challenges, hyalinized trabecular tumor and paraganglioma, they can mimic, PTC or medullary thyroid cancer, because you can have, intranuclear inclusions and salt and pepper chromatin, and those things can make you think it's malignant. So be very aware of this. And if you're not sure, you don't call, because if you call it medullary or, PTC, it's possible the patient might get a total thyroidectomy that would not have been needed. I didn't have frozens on these. These are H&Es, just for you to be aware of this. Just to show you here a classic PTC on frozen. So classic PTC here compared to benign thyroid. So what is the challenge with classic PTC on frozen? Even if it's very easy on permanence, the H&Es, this is obviously PTC very easy. The challenge is that the nuclear features of PTC, they are not, they don't have the nuclear clearing. They're not as easy clear cut as in the H&Es, okay? And what you have to do, to kind of help you out is compare with the adjacent tissue. So this is the adjacent tissue. You can see how much more abnormal these nuclei are. And that's how you can be sure you're dealing with PTC or just a hyperplastic lesion. So this is another case. I'm showing you here this FNA. This is a deep quick stain of a 56-year-old woman with a 1.5 cm thyroid nodule. And you can see this lesion is forming microfollicles. There is no colloid on the background, and it's predominantly composed of microfollicles. So this was called the follicular neoplasm. There were no nuclear features of PTC, So then the patient underwent a lobectomy, and you get this frozen section. You see this very cellular lesion, maybe surrounded by a capsule. And then you say, okay, this is a follicular neoplasm, deferred final classification for permanent sections. That, is the best you can do. They don't see nuclear features of PTC, and that's it. But then on permanent sections, you're going to evaluate the entire capsule, right? Make sure there's no invasion. And this is the H&E now. And what do you see here? You see this lesion here on the right with the capsule, and it looks like maybe the lesion is breaking through the capsule. So that might make you think, okay, now is this follicular carcinoma, right? You did not have nuclear features of PTC, did not look like anything else, but you have minimal invasion of the capsule. So am I dealing with minimal invasion of follicular carcinoma? So I was feeling weird about this case, and I decided to do stain to make sure it's thyroid. And it stands for Paxate, so is it thyroid? Well, this is not monoclonal Paxate, okay? So what happens is that if it's not monoclonal Paxate, you might have positive staining in cases that are not necessarily thyroid. So you see this case was staining for chromogranin negative for TTF. So this was actually a hypercellular parathyroid gland inside the thyroid, mimicking a minimally invasive follicular carcinoma. So I almost made a mistake, but I just felt weird about the case. I saw the cellular monotony, and I decided to do stains. And thankfully, I did not overdiagnose this case. So the challenge of parathyroid gland on frozens is because, it mimics thyroid, and that's real tough. It can be intrathyroid or intramuscular. So you really might be thinking you might be dealing with like a thyroid malignancy. And also it's very fatty, it's difficult to cut, right? So it might be really difficult to interpret. So when you look at these pictures, which one do you think is thyroid? Which one do you think is parathyroid? You kind of take a look and compare. So thyroid on the left, parathyroid on the right. And how can you tell? Well, what favors parathyroid over thyroid? I find all these features are very helpful. Okay, if you see the different cell types and if you see fat inside it, that's helpful. But what I really helpful, I really think is helpful, is the monotony of the cells. The nucleus are a little smaller, a little darker, and a little bit more monotonous. That helps me. And if you want to try this trick, okay, what would favor thyroid and not parathyroid, if you find birefringent calcium inside the lesion with polarized light. Now, if you don't find it, that does not exclude thyroid, but if you do find that is going to favor thyroid over parathyroid. So we are now going to talk about less tricky topic. We're going to talk about invasive fungal sinusitis, frozen sections to evaluate for invasive fungal sinusitis. And just to compare, this is kind of everywhere, just like the scorpions here in Arizona, kind of everywhere. But if you want to find it like in your house at night, you can use black UV light, and they're gonna look green and bright. So this is a trick for you to kind of find them at night. They're kind of very active at night. Now, let me show you this tricky case now. So this is not sinonasal, but it's the same differential diagnosis. This is actually laryngeal lesion. So you see the mucosa here is, well preserved, but under the mucosa, there is a ton of mixed inflammation and necrosis and very kind of dead tissue under this mucosa underlying here. And you look at this and you're trying to figure out what's going on. Could this be malignant, benign, lymphoma? Could this be fungus? What are these structures? Kind of, I don't know, is this dead tissue? Is this fungus? So what do you do? Okay, this is your differential diagnosis: infection, fungus, lymphoma, or could it be vasculitis, right? So you don't know, like, so what do you do in this setting? You spend your time, you look in the necrotic areas, okay? Don't wait. If the tissue looks viable, then it's not fungus. But if it's necrotic, then you're gonna have to look for fungus. And if you're lucky and you have many organisms, then you're done. You've made your diagnosis. That's good. But if you don't see, you can try to do some toluidine blue, stain slide. Sometimes it highlights the fungal organism better. If you're lucky, right, you can try that. Now, my advice, so when you're dealing with this situation that you're trying to evaluate for the presence of fungus, you should freeze all the tissue, okay? And if you don't find the fungus, you rush the case for the next day. You already have some requests for your stains, GMS, PSD. Okay, many pathologists, they actually prefer PSD. I tend to do both. And I had a case once that was negative for GMS, positive for PSD. So, that's good to be aware. And also, put an AFB in there if you still don't know what's going on, right? Now, you should be aware of this, okay? If you call fungus, the treatment will be aggressive debridement, okay? But let's say you call fungus and it's not fungus, okay? If it is not fungus, the surgeons do not want to take more tissue, okay, from a patient that is already very sick. So you don't want to overcall, okay? Now, if you do call fungus, the surgeon will still keep taking more tissue because he will try to clear the area. So he'll try to clear the margin. And you might not understand, why am I getting more tissue? I already gave the diagnosis of invasive fungal sinusitis. And the reason is because the surgeon will try to clean the area of the fungus. So we go back to our case, we look at the H&E, the GMS was negative. This is very inflamed, you see neutrophils, and histiocytes kind of aggregating and maybe vague granulomatous. What's going on? It's not fungus. I didn't see vasculitis. I'm not sure, but what else could this be, right? If it's none of this. Thankfully, I had ordered an AFB stain, and this was a mycobacterial infection. So just a lesson for you to keep in mind that you should add that stain, in the case that you're looking for these entities. This is all I have for you. I appreciate your attention. And if you have any questions for me, I'm happy to answer them. So I see here some questions in the chat box. If Rifat wants to... okay, so question about the P16 staining in branchial cleft cyst, that can happen, okay? So you have to be aware of this pitfall, and you have to evaluate in conjunction with the morphology. And if you're not sure, then you do HPV stain. HPV inside hybridization. So what's a practical approach to diagnose small biopsies from pharynx, larynx on small biopsies, especially if the concern is for squamous cell carcinoma? It's morphology. Don't do P16 if you're in the larynx, okay? You look for cytologic ETP, pleomorphism, and architectural abnormality, but on small biopsies, it can be really hard. And how confident can we be to call it carcinoma on frozen sections? Yeah, so it depends on your experience. If you're not comfortable, don't call if you're not sure, or call a colleague. In difficult cases, if you don't do a whole lot of head and neck frozen sections, don't be embarrassed, just call a colleague. You can, like, these days there is Zoom, you can share your image with a colleague. There might be even like different location, and like look up your schedule ahead of time. And if you see you're going to have difficult cases, you might talk to your friend ahead of time to make sure he's available to help you out. Okay. Can we leave it as high-grade dysplasia? So if you say, if it's invasive cancer and you undercall, then it might be a problem. But so you want to try to make the correct diagnosis, because the invasive cancer, the surgeon will try harder to kind of clear it out. Whereas high-grade dysplasia, he might leave it if he thinks it's too morbid, right? But the invasive cancer, he's going to try much, much harder. With regards to the last slide on inflammatory polyps, would you diagnose squamous cell carcinoma prefer instead of squamous cell carcinoma DDC? Yeah, so in the setting of sinonasal polyp, inverted papilloma, you don't make this distinction in situ invasive. It's too tricky. You just say squamous cell carcinoma arising in the setting of inverted papillomas. And then for positive margins, can we focus only on high-grade dysplasia if present? Yes. So just say, when you're evaluating margins, you can just say, negative for high-grade dysplasia or carcinoma, and don't worry about low grade, right? Can we ignore low grade? Yes, you can ignore low grade and just say negative for high-grade dysplasia. That is exactly right. Okay. Is there any guidelines for evaluating margins in frozen section of head and neck cancers? So yes, I have a few references. There are many textbooks about it. I can share my screen in a little bit. And there are actually lots of resources out there. So you can read, but actually it's very helpful. The more you read, the more expertise you gain, but you really, really need to look at frozens. And let's say you're new at your job, you have not done many frozens, you can pull some frozen section slides to look at them and compare, right? And try to get your eyes adjusted to how does the dysplasia and how does cancer look on frozen section. Can you distinguish paraganglioma from medullary on frozen section? Maybe, maybe not. So if you're not sure, don't overcall it. Okay, if you're not sure it's medullary, you hold back. Okay, how best to report parathyroid on frozen? Do we wait in every time? Yes, so you always wait the parathyroid gland. Sometimes the surgeons, they ask for the weight, sometimes they don't. And most times they say, parathyroid tissue identified. Some surgeons like to know if does it look hypercellular to me or not. But if you say parathyroid tissue identified and the weight, that's enough, right? Because they're going to check for the PTH levels. If they take out the parathyroid, the PTH levels go down, then they know, that was just an adenoma. And if PTH levels don't go down, then that means that's hyperplasia. Okay. Yes, we call parathyroid gland presence. So how do you report parathyroid adenoma versus hyperplasia? So you cannot make that distinction between the hyperplasia and adenoma, not even in the permanence. You just say parathyroid tissue and the weight, and that distinction requires correlation with the PTH levels. It's not a distinction you can make just by looking at it. How to differentiate PTC from papillary hyperplasia on frozen? So you compare with the adjacent thyroid. So PTC nuclear compared to the adjacent thyroid are they're bigger, they're more irregular, but it might be really hard. And if you're not sure, you don't overcall it. And what might help you, if you're good with cytology, you can make a smear and look at the smear. That might help you, okay? But again, if you're not, it's better not to overcall, because they can always go back at a later time and take the other lobe, and they cannot put the lobe back if you call it PTC and then it wasn't PTC. How to differentiate high-grade mucoep from squamous cancer of frozen section? That might not be possible, and it might not matter, because if it's high-grade, the surgeon will be a complete parotid gland dissection and complete neck dissection, okay? And that might require, stains or additional sampling. So I would not worry about trying to make that distinction on frozen section. Now, if you see keratinization, that goes with squamous cancer. That does not go along with mucoepidermoid carcinoma, okay? Could we review the slide on granular cell tumor with pseudoepitheliomatous changes? Was the paradoxal maturation? Yes, there was paradoxal maturation on the slide, and that's a good observation, and that can happen. And that is why pseudoepitheliomatous hyperplasia can be so tricky. There was an H&E slide that is actually from the WHO book, okay? So be aware of that. So you cannot judge just one feature. Paradox maturation equals squamous carcinoma. No, you have to judge all the features. You have to judge cytologic atypia, presence of dysplasia, what's under, what's going on. So like it's like dancing, right? It's a combination. What music is playing, what step am I gonna use, like of many features. You can't just go like with one feature. You have to combine everything you have. So if FNA report of thyroid is suggestive of malignancy, but is frozen section necessary in those cases? Yeah, so it's up to the surgeon, whatever he or she wants to do, right? It's like the medullary thyroid cancer I showed you, there was a previous FNA. It was called suspicious for medullary thyroid cancer. There were calcitonin level was high, but for some reason the surgeon still want to do the frozen. Then you do the frozen, and that's how it is. That's all the questions I see. Rifat, anything else?
There is
Yeah.
one more. I
Okay.
just see that. What is the best way to report on frozen section if you suspect medullary carcinoma? Do you call it medullary carcinoma? Do you call it suspicious, or is there any other ways that you would advise?
Yeah, make a smear, right? Try to use the smear. So you tell how much you can, and you be honest with the surgeon. And you have to know the surgeons and understand the kind of, he should understand what the challenge is. And if you're not sure, why is it that you're not sure? And you do the best you can, because medullary can mimic, follicular lesions, it can mimic other things. But if you're sure, if you see enough cytologic atypia, mitosis, necrosis, then it's a malignancy, right? If you see increased mitotic figures, but mitotic figures can be really difficult to see on frozens. But if you do see, if you're sure, then you call it. Or plasmacytoid looking cells. And another good clue for medullary, like I was saying, the melanoma of the thyroid, because you have multiple looks. So you have solid areas, follicular, single cells, streaming, and blobs of pink stuff like amyloid. But that might be really difficult on frozen. And yeah, so only call it if you're really familiar with the entity, and if you're really sure. And if you're not sure, it's better not to call it.
Another question here for thyroid is that what is your experience about thyroid tumor for frozen section? Do you get specimen from the metastatic side, or sometimes you get it from the primary location for diagnosis as well?
Yes, both. Yes, and sometimes the surgeons, they don't know what's going on. There is a thyroid lesion. They don't. Many times you can have even primarily you can have metastatic lesions to the thyroid presenting as a primary. Clinically they think it's a thyroid tumor, a primary thyroid tumor, and they don't know there's another tumor. So renal cancers very frequently can be metastatic to the thyroid. Lung can be metastatic to the thyroid. So those are real pitfalls. So a clue for you that you're dealing with a metastasis to the thyroid is when there's too much atypia. Like I had a case one time, it was had this papillary architecture, but there was too much cytologic atypia, there were too many mitoses, and that's not common with PTC. You don't normally see a ton of cytologic atypia with PTC. You see enlargement, outline irregularity, but not coarseness, not crazy pleomorphic looking cells. Even so, those are red flags. If it looks weird to you, you back off. That's my best advice.
Right. No, thank you. Because PTC can seem to be very challenging on frozen section, if at all we get it, because those nuclear features are best seen on paraffin sections. And if you're
Yes.
trying to look for those, so that can be very difficult.
Yeah. So the advice is compare with the adjacent background. Always compare. That's the number one clue, or the number one tip I can give it to you regarding frozen sections. You compare.
No, I think that's a very good advice. And as you said something before, maybe like we always don't follow it, is that to know the OR schedule ahead of time, and then know, at least be aware of what we are expecting for tomorrow. And if we know that this case is going to be difficult, so already reach out to someone who might be more experienced. I think that's a really good advice, because sometimes we may be struggling at the last moment and we may not have someone, who is available at that time. I think, and then
Yes.
as you also said, that the comparing with the previous slide, if it is available, like in our archive, that can be really very helpful to evaluate on frozen section, right?
Yes, I call it map out your friends. Have everybody's cell phone handy. Don't be afraid. Don't be shy. Don't be embarrassed. Don't feel bad. You do the best you can, and that's it.
No, I think that's a very good
Yeah,
suggestion that you have said. I mean, especially we will have so many residents and junior pathologists who might be watching that. I mean, we don't have to be shy to reach out to our colleagues, especially when there is so much at stake for frozen section and there is so much of like, I mean, variability and which has a lot of clinical consequence. As you said, positive margin versus negative margin, both false positive and false negative can be equally challenging and equally uh, like with a big prognostic implication for the patient,
yeah.
right?
I have one more advice. So you look at a margin and you think it's positive, but you're not sure, right? Let's say I think it could be necrotizing sialometaplasia, or maybe it's cancer, and you're not sure. You did deeper levels, you're not sure. So you talk to the surgeon. You say, "Hey, doctor, so and so, I'm worried it's positive, but I'm not sure. Can you take a little bit more? Would it harm the patient to take a little bit more?" And sometimes you say, "No, I can go take more. It's no problem." Or maybe he'll say, "No, I don't think it's a good idea to take more tissue. I would rather wait for the permanence." Great, right? Then you give him the option to decide what does he want to do. And they need to understand frozen is not perfect, right? And you're just gonna do the best you can. And it might be very obvious on the H&E, but to call something positive on frozen, you have to be sure. If you're sure, then you're sure. But if you're not, then you communicate with the surgeon and see what can be done, so that the patient can get the best care.
So there is a question like I think I always have in my mind is that, so I mean, there are situations when we get frozen section for a first time biopsy. Like, I mean, this is a frozen section from a lesion in the pharynx or the larynx, but there is no previous diagnosis on FNA or biopsy, but this is the first time you are being asked to diagnose. So that
Yeah,
can be really challenging. And what is
yeah.
your approach then if you're
Okay,
not very sure, like whether it is
okay.
invasive or not?
So let me tell you. So a couple of things. So first time biopsy, you need to understand what's going on. Why is it that right now you need to give this diagnosis? So if you're not sure it's cancer, you ask the surgeons. You can tell him, "Hey, or you're worried this cancer. I am it's a well-differentiated squamous lesion. It's atypical. I'm very worried it's cancer. I'm not entirely sure. What are you planning today? What is your plan for today?" Because he says, "No, I just want to make sure I obtain enough tissue because the patient is very sick and I want to have his care expedited. He's not doing well. And that's why I need to know right now that I have enough tissue for permanence." Okay, great. Then the end of the story. But if he tells you, if you tell me it's cancer, I'm going to do a radical resection. I'm going to take bone. I'm going to take this, take that. And you're not sure. Then you say, "Okay, I'm not sure. This is atypical." And then he decides. But if you say you're not sure it's atypical, he's not going to take more. He's going to stop, right? And then he knows that it might come back cancer in the permanent, but he's already aware what's going on. So this communication is very important. And I see very common situations that you get biopsies for patients that already had 3 or 4 biopsies before, like that squamous cancer, well differentiated squamous cancer I showed in the beginning. The biopsies were very superficial, and it was called atypical squamous epithelium with this and that. And because it was very keratinizing, it was hard to say is high grade, low, what's going on, right? And it was extremely well differentiated squamous cancer that the architecture was needed to be sure. So those kind of cases you might get frozen, and sometimes you get a little frustrated, like, why are you sending me this for frozen? Why don't you send for permanents? But there is usually a reason why. It's not just curiosity. And if it is, you have to like talk to your surgeon and make sure the frozen sections are being uh, being done in the correct cases.
I know. Thank you so much, Dr. Smith. I think these are all the questions that I found online from our viewers on Facebook as well as YouTube. And thanks a lot for this excellent talk in which you have covered something that is really practically important. And personally, like, I also in our organized institute, we do a lot of what's it called, frozen section for head and neck specimens. And I especially loved when you talked about those mimics like juxtaoral organ of Chevitz and this necrotizing sialometaplasia. I remember from my residency days, like one of our senior pathologists had this case, and then he asked me that, what do you think about it? I, of course, thought that this is positive. And then he brought up a picture of that juxtaoral organ of Chevitz, and he said that this is what it is. I am not going to forget it. I think that, again, you're reminded, because those small squamous nets can be so tricky, and we can get trapped if we don't know about these mimics, like again the necrotizing sialometaplasia as well. So thank you so much, Dr. Smith, again. And we had a lot of viewers who joined from different parts of the world. I tried to keep track. So we had over 100 viewers who joined from far off places like Chile, Kurdistan, Ecuador, Bulgaria, Ukraine, Nepal, Morocco, Bangladesh, Cambodia, India, United Kingdom, and of course, some joined from the United States as well. And thanks to all our viewers for your continued support to Pathcast, and we really appreciate it. Our next lecture is coming up, so let me share the screen so that I can let you know what it is. So this is on April 9th, so that is 12 p.m. Eastern time or 9 a.m. Pacific time. We will have a hematopathology lecture, and our speaker will be Dr. Sanam Logavi, who is going to talk about acute myeloid leukemia and myelodysplastic syndrome, especially in regards to ICC and WHO classification. I think this is going to be a very good talk. And for our followers, don't forget to follow Pathcast on the social media platforms, including Facebook, YouTube channel, and we have an Instagram account and also on X, so that you can stay updated with all the upcoming lectures. And thank you again, Dr. Smith. It was a pleasure having you. Thanks so much.
You're welcome. Thank you, and good luck, everyone.